Hello people, in this video we want to look at this topic polycystic ovarian syndrome. Basically you can also call it as PCOS or PCOD, that is the polycystic ovarian disease you can say. It's also called as Stein-Leventhal syndrome. So now let's get started with this. What do you mean by polycystic ovarian syndrome? So ovary, female, so it will affect women. Polycystic, the ovary, okay, when you look at, this is an ultrasound image, you can see that there are follicular cysts, okay, this is not ovarian cysts, these are follicles which are all having fluid, so follicular cysts these are, okay, and that is why the name. So the ovary, as such, the volume of the ovary would have increased, but what you will see is peripherally arranged follicular cysts, okay, increased in number, greater than 12. What's this? Follicular cysts, okay. So that is what is important for you to understand. And then there will be thick stroma. Thick stroma you should see in the scan. And what are you seeing here? Basically follicular cysts, multiple small, let's write it here. Multiple small follicular cysts will be there, okay. They have not ruptured. And there is thick stroma, okay. This is all you have to understand. So this is how it looks. That is why the name, isn't it? So look at this PCOS laparoscopy. How in laparoscopy it is looking. Bilaterally there are polycystic ovaries, okay. Laparoscopy. So here you can see these are follicular cysts, okay. Multiple follicular, small follicular cysts, okay. How's it going, people? So basically this is an important topic. So you have understood why the name, right? Basically what are the clinical features of these people, okay? They will come into you with these complaints possibly. They have infertility, they have OligoMenorrhea or amenorrhea, right? So that is, they have very less bleeding, you can say, right? And they have infertility. Could be a issue for some people, right? And they can have hirsutism, that is, they can have excess hair growth, they can have acne. So those are all features of HyperAndrogenism. And when you do an ultrasound, let's say, you may find multiple small follicular cysts ovary, okay? Let's not talk about laparoscopy, because why would you do something invasive, isn't it? So any of these two, if they have, you can say they have PCOS. So if you have OligoMenorrhea, that is greater than 35 days cycle, right? Amenorrhea, right? Could be that they don't have cycles. You have to rule out pregnancy, etc., isn't it? And they have hirsutism, that is excess hair growth. And if you are able to see the cysts, right? Then it follicular cysts, then it will be PCOS. Okay. So basically, there are other clinical features that they are talking about. Look at this. They can have some called as HAIRAN syndrome, you can say. That is, they can have HyperAndrogenism. That's what they are telling here. Insulin resistance they can have, because of which they will have Acanthosis, Nigricans, etc. Right? So, and Acanthosis, Nigricans is the same thing. Okay. We will come to all this, guys. Nothing to worry. Then they can have the metabolic syndrome, where they are obese, where their lipid profile isn't proper. They are high density lipoproteins, isn't it? They are less. Then glucose will be high, because all these are insulin resistance features, isn't it? So anyways, these are the clinical features. Okay. Don't worry much. We will understand why all this. Okay. There are just two causes they tell. Okay. One is obesity. So what obesity does, it will lead to insulin resistance. Insulin resistance will lead to the ovary making more androgens, and hence there will be no ovulation in this person, and they will have hirsutism. Okay, this is one theory. The other thing is genetic. Okay, genetic, something that is affecting their hypothalamus. So what will happen? The hypothalamus is making more GnRH. So the pulsatility of this GnRH is more, or the pituitary is more sensitive to GnRH. So basically these are the only two things that you have to remember. One is obesity, the other is genetic, which could lead to pituitary hypothalamus problem. Okay. So did you get it, guys? So it can happen that genetics itself can lead to even obesity, right, sometimes, and that can lead to PCOS, etc. So there are only two things you have to remember here: hypothalamus pituitary issue leading to PCOS, or obesity leading to PCOS, and any of this can be genetic, okay, genetic causes. So did you understand, guys? Only two theories you will have to remember here. Now comes the whole vicious cycle of PCOS, guys. Let's see if you can understand, okay. Here we have indicated to you the entry point for that hypothalamus pituitary thing, and here obesity we are trying to show, okay. So let's start off with the hypothalamus pituitary one. Ready, guys? So this is not going to be difficult at all. Just observe here, okay. So what happened, this hypothalamus is making increased pulse frequency of GnRH. GnRH is what? Gonadotropin releasing hormone. So for some reason it is making this GnRH more. So pituitary is making more of LH and less of FSH. That's all. More of LH, less of FSH. This is the whole thing. That's it. So now what will happen if FSH is more? FSH is less. Follicle stimulating hormone is less. So now let's come to the ovary here, down below. Here we are. Yeah, here. So FSH is less. So here, coming to the ovary, the follicle stimulating hormone is less. So if follicle stimulating hormone is less, what will happen? These follicles are not able to mature. Okay, so let's go down here. So are you getting it, guys? Here the follicle stimulating hormone is less. So the ovary, what is happening inside the ovary? The follicle maturation is less. So if there is follicle maturation is less, what will happen? It will not rupture and release the oocyte. So there is anovulation. So there is no corpus luteum, so no progesterone, so only estrogen effect is there. So now what will happen if only estrogen effect is there? The endometrium will proliferate, keep on proliferating till one level that it grows so tall that there is ischemia, and finally the endometrium sheds. And then they will get their period after many days, so they will have oligomenorrhea. Okay. So now let's get back here. So we have understood this part of it, right? So hypothalamus, more GnRH, pituitary is making less FSH leading to anovulation. Okay, now let us come to this more LH part, okay. Now LH is more. So now what happens if LH is more? LH is going to impact, it's going to work on the theca cells of the ovary, okay. So what will happen? The stroma of the ovary, what you see here in the middle, the stroma of the ovary will become very thick, and the job of the stroma is to make androgens. It makes lot of androgens. Now what happens if androgens are more? So if androgens are more, these people will have more testosterone, okay. So if testosterone is more, it will lead to hirsutism, that is hair growth, etc., right, acne, etc. So that is the other part of it, where there is more androgen because of more LH. Okay, so that is explaining some part of this hirsutism and all, it is explaining. Okay, now what happens here? Androgens are more, and hence what happens? Estrogen is also more. Estrogen you have seen, right? Estrogen is more, there is no progesterone, etc. Estrogen is also more because these multiple small follicles are making some amount of estrogen. Then there is peripheral conversion of these androgens into estrogen. So finally estrogen, more estrogen. Okay, this is what you have to remember here. There is absolutely more estrogen. So the pituitary is going to release more LH and less FSH. This is the whole thing that you have to write in the exam. Androgens are more, estrogen is more, LH is more, FSH is less. FSH is less. So where is this vicious cycle, guys? It's here. Here, look at this. LH is more. So, because LH is more, androgens are more. Because androgens are more, the conversion of these androgens happening to estrogen is more. Because estrogen is more, pituitary will make more of LH and less of FSH. So this is the vicious cycle. LH is more, so estrogen is more. So LH again becomes more, so estrogen is more. LH, estrogen, LS, estrogen, LS, estrogen. Okay. Now let us look at a little more closely this genetic thing. Okay. Hypothalamus is making gonadotropin releasing hormone is more. So pituitary is making more LH because there is more androgen and more estradiol. Pituitary is making more LH because there is more estradiol and more inhibin, okay, from the ovary. So FSH is made more, less, FSH is less. Okay, we have understood these two parts of it. Now coming to the ovary. What is happening with the ovary, guys? So basically the follicles are not maturing. So many follicles are there. It is making, the follicle's job is to make a little estrogen anyways. And basically this stroma here, because of this increased LH, what will happen? These theca cells, these stroma are making a lot of androgens they are making. And inside the ovary conversion is less to estrogen. Estrogen conversion is reduced at this moment. So everything is androgen. There is full of androgenic environment in the ovary, and there is a lot of androgen coming out. A lot of androgen is released. Now, what happens to this androgen? Mostly, it is supposed to. It will get converted peripherally. Also, it can get converted to estrogen. So finally, you can see there is a lot of estrogen which goes and signals the pituitary to make more LH. Now, coming to the other androgens. You have lot of testosterone and androstenedione in these people. Androstenedione will be more, and these people will have hirsutism, acne, etc. So this is all about the this part of it. Okay, this entry point you have seen. This part of it you have understood, right? Now let us go to the obesity, insulin resistance, diabetes mellitus, that part of it. Okay, so now let us enter from here. Okay, so we are entering now the cycle, vicious cycle from here. We look at this, okay. So this person, again, because of some genetics or something, she's obese or has some insulin resistance, let's say. So now what will happen? This insulin resistance, you see here, we have written here, insulin resistance, basically. These people will have insulin resistance, so they will have all this acanthosis, nigricans, etc. to indicate this insulin resistance anyways. So now this insulin resistance will not allow the uptake of glucose, okay. So now there will be more insulin in these people, more glucose also, and insulin-like growth factor is more, okay. So basically insulin-like growth factor is more. So what will happen? The theca cells here, because this insulin growth factor is more, right, it will make more androgen. You are understanding? So androgen production is more. Why? Because LH is more, because IGF-1 is more. Look at all the causes of this androgens. Inside ovary, more androgens are produced due to high LH, but there is no LH surge as such, okay, because LH surge is required for ovulation. LH surge will not happen, but high LH is there, okay. Then ovarian stroma has undergone what? Hyperthecosis, the theca cells and all those. That's why we told you the thick stroma is there, okay. And then what happens? This IGF-1 is more, insulin growth factor 1 is more insulin is there. Then there is less aromatization of androgens to estrogen, like we told you. Inside the ovary, conversion of androgen to estrogen is less. So androgen is more inside the ovary, okay. And then there is one enzyme which is overacting. This overacting enzyme will also help in producing all these androgens, okay. Along with this, what is happening? This SHBG, that is that sex hormone binding globulin, even that is made less by the liver. And IGF-BP, that is insulin-like growth factor binding protein, is also, what happens to this? Is less. So what will happen? As these binding proteins are all less, what will happen? Your androgens will increase and your insulin-like growth factor 1 also increases. And insulin-like growth factor 1, look here guys, insulin-like growth factor 1 will make it release more androgens, will make the ovary make more androgens. And there is no binding protein, so the free testosterone, etc. will be more. So androstenedione will be more. Estrogen also will be more because of conversion, right? So what will happen? Now here you have understood this part of it. The androgens are more, so free testosterone is more, estrogen is more. So here a vicious cycle, more LH is, again LH only it is telling to make, right? LH only it is trying to make. And here because of these testosterone, hirsutism, acne. Okay. What is this small thing here? Did you notice guys that the adrenal gland also makes androgens, but adrenal gland also can start producing more androgens because of the effect of prolactin. which is coming from the pituitary possibly. Okay. So anyways, that part of it you leave. This much did you understand now? We started off with this obesity kind of thing. Obesity will lead to insulin resistance. Insulin resistance will lead to more insulin-like growth factor, more insulin. Ovary will produce more androgens. The androgens will not convert into estrogen inside the ovary, less aromatization inside the ovary. Now androgens coming out, the androgens are getting converted to estrogen. They are also remaining as free testosterone, etc., leading to hirsutism. This estrogen going in, acting on the pituitary to make more LH, okay, and less FSH. So there is anovulation. Anovulation will lead to endometrial hyperplasia, right? And then oligomenorrhea and amenorrhea. Okay. Hope you have understood something, guys. So let us just go back to our slides. What are we looking at in this video, guys? We're looking at polycystic ovarian syndrome. We saw that how the follicles will look in the ovary, right? Because all these follicles are not matured and they are not ruptured. So they all will look like cysts. So this is what is it? It is not ovarian cyst, it is follicular cyst. Okay. So that's what they're showing in laparoscopy. So now you can understand the clinical features. What will they have? Anovulation. But who will come and tell you in the hospital that they have anovulation? They will come and tell you they have oligomenorrhea or amenorrhea. They'll have irregular cycles basically. They can come with facial hair or acne. And when you do ultrasound, you can see multiple cysts, okay? Follicular cysts. Guys, focus. They can also come up with what all these? So they can come with acanthosis nigricans, okay? HAIRAN means HA is HyperAndrogenism, IR is insulin resistance, and AN is Acanthosis nigricans, okay? Metabolic syndrome, I would put it like this. Acanthosis nigricans, insulin resistance, same. This will lead to hyperandrogenism, okay? Metabolic syndrome, obese, they can be obese, triglycerides can be more, high density lipoprotein can be less, BP can be mildly more, glucose can be slightly more, okay? Guys, focus. We are just, after looking at that vicious cycle, we are coming and trying to understand this clinical features again. Okay, so these people will have what basically you can see here. In a normal menstrual cycle, the FSH is slightly more in the beginning, right? And then there is an LH surge in the center, LH surge, and then there is, you can see here at this LH surge, the follicle will rupture and release the oocyte, okay? This is how it is. But in PCOS cycle, there is no LH surge, but LH is more than FSH, okay? And you can see that at the periphery, you have all these follicular cysts. So that is why it is called as polycystic ovarian syndrome or disease, you can say, or disorder, whatever it is. I think disorder is a better word. Disorder. Okay. Now where are we, guys? Here. Okay. So now let us, the first theory of obesity, let's revise. Obesity, fatty acids are more, so there will be, the body will try to bring insulin resistance so that you can burn the fats actually. So there is insulin resistance, so there is increased insulin, more insulin-like growth factor. So there is more androgens, more estrogen, so LH is more, FSH is less, anovulation, etc., continues, okay. And obesity will lead to depression maybe, and less physical activity, and that can again lead to obesity. Obesity can lead to obesity. Obesity now, because of this insulin resistance, right, can lead to diabetes mellitus, isn't it? Then, so what is actually leading to diabetes mellitus? It is the insulin resistance. I don't think it's the PCOS, but anyways. Now coming to the other theory, what did you understand so far? That there can be a genetic cause, nothing to blame the obesity. The person may be perfectly thin, everything. And hypothalamus issue can be there. The gonadotropin releasing hormone will be more. Pituitary issues will be there. It will, because it reacts as estrogen is more, as estrogen is more, LH will be released more than FSH. FSH will be less, so there will be follicles will be immature, anovulation will happen, no oocyte is released, so no progesterone, oligomenorrhea, endometrium sheds after becoming too tall and hence ischemic. Now what will happen to LH? LH is more, so there will be the ovarian stroma, that is the theca cells, will make more androgen, so there will be hirsutism. Androgen will convert into estrogen, estrogen will be more. So what will happen? LH should become more. So now it will work on the pituitary and it will lead to LH release. Okay, more than the FSH. So now let's go here. So this is the vicious cycle you saw. So when you do investigations in these people, what will you find? Then we'll come to the treatment, guys. Just focus your investigations. What will you find in these people? Basically, you only can say now. Very easily you will say. What will you find? You will find raised levels of estradiol and estrone. Fine, fantastic. Okay, this is E1, isn't it? This is E2. Okay, these two are elevated. Okay, and LH level is elevated. Yes, we know. And FSH is less than LH. So if LH-FSH ratio is greater than 2.2:1. Great, you should say that. SHBG level is reduced. Yes, sex hormone binding globulin is reduced. Yes, you know that. The liver is making less of it because of insulin resistance. Okay, hyperandrogenism. Hyperandrogenism, yes, we told you hirsutism, acne, etc. So what is more? In the blood, you will see ADD is raised. What is ADD? Androstenedione. Okay, androstenedione is raised. Okay, and androstenedione. The two D's are coming from here actually. Andro. And then there is testosterone. Testosterone level is more. Yeah, we know that everything is more except FSH and okay, this one is also less. Okay, SHBG. Now insulin resistance will be there. How will you prove insulin resistance? Insulin should be more. Yeah, that much we are sure of. Insulin should be more. See, raised fasting insulin. Okay, insulin is greater than 25, they are saying. And fasting glucose insulin ratio is less. It is really strange to understand. And level of serum insulin greater than 300. Oh my god, if it is greater than 300, it suggests severe insulin resistance. Okay, so insulin resistance, insulin will be more. That's why body is making so much insulin. But the body is itself not able to use it after making so much insulin. So it cannot use it because it has insulin resistance. Okay. So these are the investigations, guys. Did you understand the investigations? Can you say what and all is elevated? FSH is more, estrogen is more, androgens are more, testosterone is more, FSH is less, SBHG is less. Very good. Very good. Very good. And what else is more? Did we cover everything? Insulin is more. Okay. That also you see. Now, what is the treatment? The treatment is difficult to understand here. Okay, we will go into that cycle thing and we'll explain the treatment. Treatment has been added to this diagram in green. Okay, so let's get started here. Guys, generally look at the treatment. Okay, then we will tell what exactly to do. Let's just zoom here and look at all the greens. Okay. Okay, here we are. Clomiphene citrate you can give to stop this feedback of estrogen. What does clomiphene citrate do? It has anti-estrogen effect. Okay, guys, estrogen here. You can see anti-estrogen effect. So obviously, you are going to give clomiphene citrate. So anti-estrogen effect, clomiphene citrate. One drug you got already. Okay. Let's see here. For hirsutism acne, they are saying cosmetic therapy. Okay, fine. Let's look at the green here. Let's look at this. You can directly give FSH, they are saying, because FSH is less. You can give FSH, they are saying. Look at this one. This androgen conversion to estrogen peripherally, that is happening because of peripheral aromatization. They want to give letrozole to stop the conversion of this androgen into estrogen so that there will be less estrogen. Letrozole is an aromatization inhibitor. Okay. So letrozole, guys. See, it's written here, aromatase inhibitor. Letrozole is very important to remember, so know that. Okay. Now let's come to the other anti-androgens which you see here. Are you able to see, guys? I hope you are able to see. See here. This there is some anti-androgen here like spironolactone, finasteride to stop all that hirsutism and acne and all that. Okay. Now look at this one more thing around here on the androgen only it is talking about. See, you want to make less androgens. That time what they are doing, you know, they are going on this ovary. Okay, this ovary you can see here. And they're trying to burn out laparoscopically, they're trying to drill and reduce this ovarian stroma. So the theca cells will reduce, so androgens production also will reduce, okay. So that is an invasive thing, but laparoscopic ovarian drill to reduce stroma thecal cells, okay. So did you understand everything about this androgen? First, production of androgen itself you can stop by burning out this ovary part. And then anti-androgens you can give like spironolactone, finasteride. And you can also give letrozole to stop the conversion of this androgen into estrogen, so that the pituitary it will not act on. Okay. Now look at this one here, guys. Come here, guys. Focus here. So look at this. This metformin at an entry level itself, it seems to be controlling, because insulin resistance itself we can avoid. Okay. So that is about metformin. Just from up, let us see if we have covered everything. You heard about clomiphene citrate, cosmetic therapy for this hirsutism acne. FSH also can be given. Letrozole to stop the aromatization of the androgen. Anti-androgens like spironolactone, finasteride for the acne, for the hirsutism. Laparoscopic ovarian drill to reduce the androgen secretion itself from the, not secretion, production from the ovary. Metformin to reduce insulin resistance. Okay. Guys, are you feeling good? Shall we go down here and look for some more things? Look here. Basically, down here. See, because these people don't have a corpus luteum, they don't have progesterone, and that is why they are not able to have a progesterone withdrawal and a normal menstrual cycle. So what they are doing is they are planning to give progesterone from the 20th to 25th day of the cycle, that is for 5 days. Then after that they will stop. Then because of a withdrawal of progesterone, they can get a bleeding on 28th day. So they can have regular menstrual cycles. But however, still this will be anovulatory. For ovulation, etc., they didn't do anything. So this was just about getting a regular cycle. Okay. And because combined oral contraceptive pills have progesterone, you can give combined oral contraceptive pills also if you want. Okay. So basically this progesterone etc. is just to regulate the cycles. If you want that person to have ovulation, then you should make sure that FSH is more and LH is having an LH surge. For that you will have to go back here into this vicious cycle and give these type of drugs like clomiphene citrate, letrozole, etc. Isn't it? Reduce the androgens, reduce the estrogen, and LH should be more like LH surge and FSH should be more. So you'll have to work on this. Okay. Or they can just, you can suggest a weight loss, and weight loss itself can lead to more insulin uptake and the entire thing can stop and the person can have a normal regular menstrual cycles with ovulation. So weight loss has been added as a solution here in green. Guys, if we do not, if PCOS is there, what can it lead to? What can it lead to? Basically, this anovulation and this endometrial proliferation will lead to endometrial hyperplasia that can lead to endometrial carcinoma. Okay, so that's what you have to focus your attention on, endometrial carcinoma. Infertility, in case they have an issue, then only infertility, right? Infertility, endometrial carcinoma. What else can be there? Because of this, not because of PCOS, I would say, because of obesity, insulin resistance, they can develop a diabetes mellitus type 2, and they can also get dyslipidemia that can lead to hypertension, cardiovascular disease. That's why they said BP can be slightly more, is it? Okay, what else? Now we have to look at the treatment. If the person wants family, what to do? If the person is not desirous of fertility, what to do? Okay. So let's arrange the treatment. Treatment, basically you can say weight loss. If fertility is not desired, we already told you, give progesterone or OC pills. Basically, they'll get their cycles will get regularize the cycles, and also you can prevent endometrial carcinoma hyperplasia. Okay. And then you will all give this cosmetic therapy for hirsutism, etc. Okay. You will have to treat the insulin resistance if it is there, metformin. Obviously, you want the person to have diabetic kind of treatment. Here you are talking about letrozole, clomiphene citrate, again metformin. Okay. Cosmetic, same thing, anti-androgens they are talking about. And we also talked about that laparoscopic ovarian drill, right? We have written that here, LOD, to remove ovarian stroma, so less androgens. So guys, one more thing they have written here is for morbidly obese, you can do a bariatric surgery. So basically this is the treatment of PCOS. So in this video, we have tried to understand this polycystic ovarian syndrome, PCOS or PCOD, Stein leventhal syndrome also you can say. Basically in this, what you will see in the ovary, there will be follicular cysts, small immature follicular cysts, multiple of them, more than 12 you can say. These don't rupture, they don't release the oocyte. So that is what is the problem here. There's thick stroma. So the ovary is a more androgenic environment than an estrogenic environment. So there is follicular immature. Maturation doesn't happen. Okay. So in morbidly obese people, obviously you cannot do ultrasound, right? They are obese, so you can do a transvaginal ultrasonography. Laparoscopy is showing to you this kind of cyst, okay, follicular cyst. This is not ovarian cyst, remember. So now coming to clinical features, you will see that these people will have three things should be there: amenorrhea or oligomenorrhea. You have to rule out the other causes of amenorrhea. Just say oligomenorrhea, that is better, I feel. Oligomenorrhea, hirsutism, and in the ultrasound or somewhere you will find that there are follicular cysts. Okay, follicular cysts in the ovary. So out of these three, at least two should be present to call it as PCOS. There is another HAIRAN, that is HyperAndrogenism, insulin resistance, Acanthosis, Nigricans. Okay. And metabolic syndrome, they can be obese, triglycerides can be more, HDL can be less, BP can be mildly more, glucose can be slightly more. So what is this Acanthosis nigricans? You are hearing it so much. Look at this image here. Here in the neck you can see here, they are showing you these black patches. Yeah, hyperpigmented. These are Acanthosis nigricans. This is because of the epidermis something, right? The superficial. And acne they are showing here, and they are also showing hirsutism. You see any increased hair, facial hair? Okay, in PCOS people, basically what happens, you can see comparison between a regular menstrual cycle and a PCOS cycle. In a regular cycle, menstrual cycle, you can see that there is LH surge, right? LH surge, and during that surge there is an ovulation. The mature follicle releases the oocyte, and you can see here FSH is slightly more than LH, right? But in a PCOS cycle, the LH is more than FSH, and there is no LH surge, and there is no ovulation. There are just some small follicles sitting around at the periphery. The ovarian stroma also is thick in the center. That's what they have shown. Okay, and we understood that the cause can be obesity, which can lead to insulin resistance, which can lead to more insulin like growth factor 1 and more insulin, leading to the ovary producing more androgens, which will actually get converted into estrogen, which will lead to LH being more and FSH being less. So this will lead to anovulatory cycles that will lead to your oligomenorrhea. Okay. Then theory 2, we saw that there is basically a hypothalamus or a pituitary issue. The estrogen sensitivity of this to this GnRH is more. So the pituitary glands are producing more LH than FSH, and there is no LH surge. FSH is less. So there is same thing. Follicles are immature and ovulation happens. So there is oligomenorrhea and infertility because of anovulation. Okay, guys. Now, because of this LH being more, the ovary will produce more and more androgen, and hence that androgen will lead to hirsutism, etc. It will also lead to excess estrogen, which will lead to the pituitary again producing LH more than FSH. So this is the whole thing that we learnt in a summary. This is the cycle that we saw, the vicious circle. And investigations when you do, you will see that LH is elevated, estradiol is more, estrone is more, androgens are more, testosterone is more, insulin is more, and the only two things which are less are FSH and SHBG. Okay. Now the treatment of PCOS basically is weight loss. Morbidly obese people can get a bariatric surgery, but this is only if there is obesity. If there is no obesity, then if fertility is not desired, you just want to regularize the cycles, give them progesterone on 20th to 25th day, you can say for 5 days, then withdrawal of progesterone will lead to the cycle on 28th day, so their cycles can get regularized. Cosmetic therapy for all that hirsutism, acne, etc. Metformin for tackling insulin resistance if it is there. patient's desirous pregnancy, you'll have to make sure that they ovulate. So you want to give them an aromatase inhibitor like letrozole to then you can give them clomiphene citrate, which is anti-androgen, so it will stop this effect on the pituitary gland. You can give FSH itself. Okay, then you can give metformin to remove insulin resistance. For hirsutism, you can give anti-androgens like spironolactone, etc. You can also do an laparoscopic ovarian drill to remove the ovarian stroma so that less androgens are produced. That's it, guys. In this video, we have covered this topic, polycystic ovarian syndrome. Bye-bye. Guys, in this PCOS genetic cause, they think that it is dominant. It's a dominant condition. So if the mother or somebody has it, then there's 50% chance that the child, basically it will express itself. So it is dominant. They're suspecting it to be a dominant condition. Not much known. Polygenic, they say. Okay.